All right. So, good evening, everyone. This is our first grand rounds in the new year. Thank you for joining. And I'm going to just make a few slides so that we can distribute our CME and MOC credits for getting the lecture. All the lectures are going to be on the YouTube channel for the division. You can go there and watch them. And for getting your CME credits, please text 32048 to the number 888-816-4893. And you can use this as an SMS message within the next 12 hours. And for those who want to get MOC credits, please use the step one, the CME credit, followed by completing a brief quiz. And this quiz link will be displayed again in the chat box. You can use that and you use the room code future 2026. And if you answer the questions correctly, directly goes into your ABIM accounts. And with that, uh, it's my great pleasure to introduce today's speaker, Jordan Strom. Dr. Strom, welcome. Dr. Strom is a close collaborator, colleague, friend. We work very closely in the American Society of Echocardiography. In fact, he's the abstract chair for this year, and I'm the abstract co-chair. So he's going to be becoming the scientific session chair next year. So we look forward to working closely. We also collaborate on several research projects. Dr. Strom has had a meteoric rise in a very short period of time. He's a physician scientist. He serves as the director of the echocardiography laboratory at Beth Israel Deaconess Medical Center. And he's also a R01 funded investigator and the section head of the cardiovascular imaging research at Richard A. Susan F. Smith Center for Outcomes Research in Cardiology at the same center. He has had a terrific career. He's been throughout in Harvard, right from his medical school, internal medicine, cardiology fellowship, advanced cardiovascular imaging fellowship, and subsequently he joined as a faculty. Currently, as the director of echocardiography lab, he's the associate professor of medicine and his focus of work has been in not only cardiac imaging, but also cardiovascular outcomes research. He has currently a track record of funding. He has an R01 and he's a co-investigator on two R01s with PI, with several industry grants and several intramural grants. He also has had the NIH NHLBI K23, F32, and AHA Career Development Award. He has over 125 peer-reviewed publication and serves in several international and national societies in the field of echocardiography. Besides his work in mentoring at his own center. He has also risen very rapidly in ranks at the American Society of Echocardiography. He was the board of director, one of the youngest board of directors in 2021. And subsequently, he has also played active role in the American College of Cardiology. In 2025, he gave the Kalmanson Lecture with honors. And he has prolific activities as guest editor, editorial board in several journals. And besides that, as I mentioned, he's also actively shaping the scientific field by being the scientific session chair in the year to come. He has had several numerous mentoring and teaching awards, and he was a chief fellow in the 2016, 2017. Today, what he's going to do is he's going to talk into something which is plays a very critical role in cardiovascular imaging, and that is microbubbles. He's probably going to dabble into a little bit of the physics, and perhaps he's going to then expand into medicine aspects of it. With that, Jari, the floor is yours.
Well, thank you. That was a wonderful introduction, and it's really always a pleasure and an honor to see you and see the rest of the great division you have here. Hopefully, can share the screen effectively and people can see. Are you seeing the right view? Is this
Perfect.
the
It's
perfect?
perfect.
Great. So Partho asked me to talk about something that was a little distinct from prior grand rounds, and that is really another passion of mine, which is microbubbles. And I think a lot of things we do in cardiology from a diagnostic standpoint don't necessarily overlap with the therapeutic aspects, except through the improving our diagnosis or allowing us to be able to get the right patients to the right place at the right time. But in fact, microbubbles are a little bit different than that. And so I'm going to borrow from the comments in the lecture and from others and talk about really how there's really a shift that's being undergoing right now, and that's from microbubbles to medicine. And as way of disclosure, the most relevant one here is that I am secretary for the board of directors of the International Contrast Ultrasound Society, which is a society formed of individuals who, across radiology, GI, cardiology, and other disciplines, who share a common interest and value for microbubbles. So I'm going to start with some overall statistics, which is why do we need imaging overall? And those of you who have been around a couple of years ago, you may remember this slide. This is from data from Ontario, looking at the utilization of multimodality imaging. And while we can hem and haw about the use of cardiac MRI and CTA and all these wonderful technologies we have, they still represent a large minority of the number of studies that we're doing, with really echocardiography as a whole being several times more frequent. And that's true both in terms of utilization, but also in terms of cost. Again, from Ontario, this is looking at total cost relative to other forms of imaging, and resting echocardiography in this particular case was increasing faster than that of some of the other imaging modalities. Now, that's Canada. Obviously, Canada has a very big difference in their healthcare system than us. So what about the US? And so this is data from Beth Vernig from AHRQ, who publishes several sort of data points about them. And they did one back in 2011 looking at utilization of echo. And it turns out that about 20% of all Medicare beneficiaries receive an echo in a given year. And in fact, many receive more than one echo in a given year. And there's massive variability by state in terms of those who are eligible to receive an echo who are actually receiving that. So lots of use. So the question then is there value to that, and what can we do? And so this is a recent paper we worked on, was just published this past month in JACC Imaging, looking at 64 million Medicare beneficiaries, about 86% of the total cohort of Medicare from 2018 to 2021 across 3,900 sites across the US, and looking at where the imaging is actually distributed. And these blue dots here are imaging centers. The red area is within 16 miles, 5 miles, 5 to 10, and then 10 to 20 miles of an imaging center. So you can see most are sort of concentrated really on the East Coast and middle part of the country, and there's a whole lot of mountains in between that and what we end up seeing on the West Coast. That being said, I think if you look at where the population lives, if you look at people's residents, and 95% of the US population lives within 16 miles of an imaging center, and 99% of those imaging centers are capable of performing an echo. And we had a very loose definition for this. So greater than 10 echoes in a given year. If you build for more than 10 echoes, we considered you a center capable of performing echo. And so we're talking about a low bar here, but a lot of people have access to sites certainly performing echocardiograms. Once you start to go to cardiac CT, cardiac MRI, and PET, that really drops off quite dramatically, where we're talking about only about 0.9% of those centers are capable of performing cardiac PET. And what was very interesting is we looked at the relationship of that distance to receive, and found that in fact the people who live closest to the imaging centers were actually the least likely, in fact, to receive those imaging. Now, that's not true in rural settings where any distance is associated with decreased receipt, but in the urban centers, particularly those people in sort of the 0 to 5 miles or 0 to 10 miles from an imaging center, those are really the people who get the least amount of receipt. And it argues that, in fact, actually access and proximity are not the same, and proximity is insufficient for access to care, as we see in many of these urban care centers. And this is just showing this same diagram, looking at the by modality. And so you can see in the upper left-hand corner that echo really is everywhere. But then once you start to get to cardiac CT, MRI, and PET, some of these advanced modalities, our ability to be able to perform those services drops off quite dramatically. And so while we like to say that the guidelines should include things like cardiac CT and cardiac MRI and PET, realistically, we in our ivory tower of academia are writing guidelines that may not be able to be applied by, in fact, a lot of the country unless we recognize those access limitations as being acute. And this is just a zoomed version looking at that in the New Jersey metro area. I figured this was a nice way to sort of take it home. And then you can see that, in fact, actually echo is everywhere, SPECT is even everywhere here, but CT and MRI seem to me more limited, although I can tell you more so, there's more CT and MRI there than many parts of the country for that matter. And like I said, the really threshold distance depends on the modality, and the median distance to travel is quite significantly influenced by that too. So it's about 3.4 miles to echo, whereas if you start to look at things like MRI or PET, it's much longer. And PET, the median travel distance was 89 miles. And with some people traveling as much as 200 miles to be able to get to a PET center. And so that really creates some challenges for access. And it begs the question that, giving this limited access to multimodality imaging, how do we make echo the best it possibly can be and the most versatile use of technology, because that is our workhorse and is ultimately going to be able to allow us to be able to do a lot of things. And contrast, I would argue, is a essential part of that. So what is contrast? And I'm going to use the term contrast or UEAs or sort of or CUS, or contrast ultrasounds, somewhat interchangeably throughout, but we prefer the term UEAs for ultrasound enhancing agents to distinguish them from iodinated contrast, which a lot of our patients hear the term contrast and assume that there's renal effects or otherwise, and so we want to use the term UEAs. So what they are is compressible microbubbles, anywhere from 1 to 4.5 microns in diameter. And that's relevant because the capillaries in our lungs are about 5 to 7 microns in diameter. And so these are just small enough to be able to get through the pulmonary capillary bed into the left ventricle, where they can exert their mechanism of action. And they consist of a high molecular weight gas followed by with a phospholipid or an albumin shell. Why high molecular weight gas? Well, if it was a low molecular weight gas, it would just diffuse out and we would lose any kind of persistence in the signal. And then why a phospholipid or an albumin shell? If you have a really thick shell that's impermeable, the gas is not going to diffuse, but you also don't have this sort of oscillation or ability to be able to have deformability of the microbubble, whereas this gives us that nice balance. And what happens is, if you put this in an ultrasound field, it oscillates between compression and expansion in response to ultrasound. And it turns out that the compression is less than the expansion. And so therefore there's this nonlinear signal that it gets emitted that allows us to be able to selectively look at the blood pool and allows for effective tissue contrast. And this is now FDA approved for LVO pacification for suboptimal image quality. And this is what it looks like. This is about the best of the animations I'm able to do here. But essentially is ringing a bell, and that bell, that resonance allows us to be able to pick up on the signal. And there are 3 brands that are available in the US. Lumazon, which is the largest internationally, but about 25% of the market here in the US, also known as Sonoview abroad, is made by Bracco Diagnostics. It's a phospholipid shell with a sulfur hexafluoride gas. Definity, which is also known as Luminity abroad, is made by Lantheus Medical Imaging here in Billerica, with a perfluorine gas and a phospholipid shell. And then Optison, which is made by GE Healthcare, and that is an albumin shell with a perfluorine gas. The contraindications are pretty straightforward to these. Certainly, if anybody has any allergies to the core ingredients of that, we'll talk about PEG, which is one of the excipients that's used in the production of the microbubbles, and it's been associated with a number of allergies in a bit. But sulfur hexafluoride, so not sulfa, but sulfur hexafluoride, is an allergy to Lumason, allergies to perflutrin for Definity. And then for Optison, the relevant thing here is if you happen to have a Jehovah's Witness patient or somebody who doesn't want blood products, it is made from human albumin, so it is a blood product that may be of relevance. The storage mostly is refrigeration, with the exception of Lumason, which is used within 3 hours of suspension. And then the rest of them, if you use the Lumason, you activate it. You can reactivate it if you don't use it within 12 hours, but otherwise, after you've activated it, you don't want to use it thereafter. And then Optison, you take it out of the fridge. You want to use it within 24 hours of taking it out. There are other agents. Sonazoid is one that's produced by GE abroad. It's used for liver and breast imaging and focal liver imaging, and they are working on actually bringing this to the US, but it may be some time before they actually get to it. It's a very large bubble. So 3 commercially available. This is kind of what it looks like. The Lumason comes as a lyophilized powder. You reconstitute it with a saline bullet that's provided through this spike, and that then draw it up and use it. And that process sort of activates the bubbles themselves. Definity needs to be physically, mechanically agitated or activated using a Viomix, and then administered. And then Optison is drawn up and given. And I'm not going to belabor this as much as I will have a tiny bit of physics in here. I think that there's a lot of physics in this whole field, and in general, I think the relevant parts here are summarized in a guideline we released a couple years ago, looking at the protocols for use of contrast echo. And I would refer you to this document, which is, I think, a really great publication and goes through a number of different details on how to set up an ideal equipment settings for this purpose. We will talk about one of the other uses for microbubbles, which is that of perfusion imaging. And in general, microbubbles are about the same size and function like mini red blood cells. It turns out that about 90% of our blood volume in the myocardium is within capillaries. And so the saturated signal that we see from the microbubbles reflects the capillary blood volume. We also know that the rate of refill is proportional to that of myocardial blood flow. And so the capillary blood volume is, blood velocity is typically about 1 millimeter per second. That means for a given normal heart, you would expect to refill within about 5 seconds at rest. And so what we can do is we can give high mechanical ultrasound pulses at varying sort of cycles that can be used to clear all the microbubbles from the field and allow it to refill over time, and that can be used to plot a capillary refill curve that ultimately gives us a sense of the degree of perfusion. We use a low MI setting. Again, I'm not going to talk too much about the physics here, but a low ultrasound power setting, which allows us to not only have the persistence of these signals, but it ensures that virtually no tissue signals are produced. And so we're just looking at the signal from the microbubbles themselves. And this is just an example of what this would look like, and you can use this quantitatively, and I know this is a tough thing to see, but over the septum there's a red region of interest where you can see that there's normal filling, and in fact you can see just visually that there's normal filling from the intensity of the microbubbles there, but also you can see with that yellow region of interest over in the anterolateral wall, there's very much a blunted upstroke and as well as a blunted total blood volume, and that's an area where there in fact was a coronary obstruction. And so at maximal so you can use this to be able to get a sense of perfusion even in the case of an echo. And at maximal hyperemia, you would expect that the myocardium fills within 1 second or 1 cycle. So that's about, with exercise, you'd expect it to fill within 2 to 3 cycles. And generally speaking, if you don't see that, then that means there may be a perfusion defect. The number of uses of microbubbles is plentiful, and this is just a summary of some of the data that's been put out there. We know that volumes in general are larger with those when contrast is used, and that in fact it's actually those volumes, and in fact the EF itself is similar to that of cardiac MRI, which is our gold standard, and with reduced interobserver variability for things like ejection fraction measurements. We also know that regional wall motion assessment, which is pretty fraught to begin with, as it comes to, we know that there's only moderate interobserver variability across physicians in regional wall motion assessment, but that's improved with the use of contrast. and particularly when using it in the case of technically difficult stress tests, where it improves confidence, sensitivity, and specificity. Because it's a marker of anything in the bloodstream, we can use it to detect intracardiac masses and can help distinguish between avascular and vascular structures. We can use it to identify apical hypertrophic cardiomyopathy, or really any abnormalities at the apex altogether. So if there's an aneurysm there, for instance, which may change management and result in the need for a defibrillator in these patients because they remain at higher risk for arrhythmia. And in some small studies, at least on TEE, TE is a little bit tougher because of the frequency is higher, so there's increased bubble destruction, but it can be used to be able to improve confidence for thrombus exclusion prior to cardioversion, and at least in one small trial was associated with a reduction in embolic events. But of course, we use it a lot for stress, and for that reason, it improves accuracy, reproducibility, and reader confidence, and is associated with lower downstream testing and costs. And I'll show you some of the data off of that from some of our own literature as well. And then you can use that perfusion imaging. You could use it qualitatively, or you could look at the actual region of interest in the quantitative uptake there. And for dobutamine, inotropic stress, it improves coronary disease detection versus wall motion analysis alone, helps define the extent of wall motion, and in fact improves upon wall motion analysis to identify people at risk. In Europe, they use a lot of vasodilator stress echo. So you use high dose adenosine vasodilator stress echo. And in that case, it shows equivalent specificity and higher sensitivity than SPECT, but enhanced prognostic value, in particular in those left bundle branch block cases where you may have non-ischemic wall motion abnormalities. It helps improve the detection of ischemia versus SPECT alone. And then if you do quantitative analysis, it has a sensitivity and specificity really greater than 80% versus our gold standard of angiography and superior prognostic information. So, this is some data that we produced from a paper we published in JACC Imaging looking at 80,000 individuals with acute MI who were hospitalized. Those who received an echo within 60 days of discharge, only about 8% of those received contrast. We know the rate of suboptimal imaging quality as a whole is probably around 10 to 20% across multiple studies. So this is low, but not quite as low as I'll show you for the overall group. Contrast was associated with a lower rate of cardiac non-stress imaging and numerically lower, though not significantly lower rates of cath. It interestingly was not associated with differences in readmission rates, days alive at home, out of the hospital, or cost, although the cost was about $1,000 cheaper in the group that did receive contrast overall. And this is not a open and shut case. This is some work from from the Netherlands, from Nico de Jong, who's a fantastic physicist based out of University of Leiden. And one of the challenges we've realized over the course of imaging people is that myocardial contrast enhancement is great, but it's challenged by rib and lung attenuation. The contrast itself can attenuate the ultrasound signal, and there's a whole lot of noise and clutter from these linear signals. And it turns out actually that myocardium itself also has some degree of resonance. And that myocardial signal itself can be picked up as a nonlinear signal, and so therefore it can contaminate the signal that we get from the contrast blood pool. This uses a higher order singular value decomposition method to be able to help distinguish what's in fact tissue, blood flow, and noise with selective filtering of pulse information. And all that allows really to be able to see things that in fact are true signals, not artifacts, as you can see so on the left here under A, you can see amplitude modulation, and then to the right with this signal filtering, and you can see that quite a bit of signal that is at the apex gets selectively filtered out as noise. We also are using these microbubbles quite a bit more for targeted molecular imaging. In many ways, in fact, this is an ideal blood agent that can be used to target certain areas of interest and visualize those selectively. And so in this particular case, It's looking at microbubbles can be targeted to an endothelial selectins that are rapidly producing in this setting of ischemia. And so at the right here, you can see really seminal work by Brian Davidson and colleagues, and Jonathan Lindner, now at UVA, but Brian's at OHSU, looking at where the signal is being picked up. And you can see that, in fact, actually there are microbubbles that are signals that are being picked up over really around the apical region, which is in fact actually where the area at risk was in the setting of ischemia. Alternatively, you can use these enriching shells that have anionic phosphatidylserines that allows, or selectively allows, for increased uptake and adhesion to leukocytes through the complement pathway, and that allows you to be able to visualize areas of inflammation in a similar kind of fashion. We can also use the actual cavitation mechanical effect of actually breaking up the microbubbles through high ultrasound pulse, MI ultrasound pulses, to result in improved clearance of clots. And so this is something known as sonothrombolysis, and typically it's a high an infusion of ultrasound enhancing agents with high MI pulses for sort of a greater course of about an hour at the time of delivery of thrombolysis. And what that does is it breaks up the actual ultrasound clot, or breaks up the clot itself, and allows for better penetration of the TPA into the clot itself, and to be able to allow for a more sort of vigorous restore of blood flow. And this has been looked at both in vitro, but also in vivo, and this was a cluster randomized trial that was done in Brazil by my colleague Wilson Mathias. Individuals who had their first STEMI were randomized to PCI versus PCI with contrast infusions and high MI ultrasound before and following. And in fact, actually, in this case, there was improved ST segment resolution, improved angiographic canalization, smaller infarct size when looked at by 72-hour MRI. And importantly, I think for our patients, there was actually a lower need for implantable defibrillators in these patients who received this. So lots of things that are potentially on the docket. But this is just the start. Microbubble cavitation can be used to also disrupt the blood-brain barrier and to deliver high doses of chemotherapeutic for brain cancer treatment and other tumors. It can be used to protect microRNAs and DNAs from immune destruction, which is led to enthusiasm for its use as a vector for gene therapy. And that really sort of ultimately represents a potential new frontier for cardio-oncology, leveraging skills and technology of ultrasound ultimately to therapy, with the idea being sort of so-called theranostics. And these aren't just theoretical ideas, and this is from one of my colleagues at Bracco, who has announced already partnerships with Canadian and Taiwan companies to develop ultrasound therapy platforms for multiple brain cancers that are in development. As well as we could use this for looking at specific markers. Like I mentioned, in theory, you could look at individual areas of ischemia. This is something that is now in testing. Believe it or not, it's being undergoing phase 2 clinical studies, which is BR55. It's a microbubble that's complex to a peptide that has a strong affinity for the VEGF receptor. So that has shown a strong promise for being a molecular imaging agent for angiogenesis and inflammation. It's now in its early human trials. And as you can see in this video here, this is basically electron micrograph showing blood flowing, and with these arrows pointing towards microbubbles that are in fact stationary in complex areas of the blood pool where there's in fact angiogenesis occurring. If you look at the left hand, you can see that there's a typical washout curve that happens with a normal non-targeted contrast agent. By 5 minutes, there's almost no signal seen. But with BR55, even at 10 minutes, there's a persistent effect in areas where there's ongoing angiogenesis. And what the reason I'm so excited about all this going on right now is, in fact, actually, there's a lot of things that are bringing the forces together to allow for not only the ability for us to be able to study and use these agents, but also to administer them with a little bit better ease and more routinely, being more specific about our dose that we're administering. And while there is a dedicated pump that exists now in Europe, that they're working on bringing the pump probably Q1, so now, to the US, to production market. And this essentially has a dedicated tubing and infusion pump that allows for standardizing the dose and reproducible infusions. And it's going to be on the market for clinical use relatively in short time. But all I've shown you is a very pie in the sky, and I think what I wanted to show you is, in fact, the sobering reality of this is not the case. We have, and others have done a lot of work looking at the use of contrast, and in fact, it's really underutilized relative to need. And so this is data from our institution, 171,000 echoes, 100,000 patients over 18 years. And if you just look at the rate of contrast receipt, the probability of contrast receipt, that's in the blue here, you might pat yourself on the back and say that we're doing a great job as an echo lab. But in fact, that only tells part of the story, because in fact, actually, the rate of suboptimal image quality, that is the denominator of patients for which we potentially would consider use of this, has actually increased more so and at a faster rate than that of ultrasound enhancing agents. Overall, we know about 2.6% of echoes got contrast. That's woefully low. As I said, we know that the rates overall should be around 10 to 20%. And in fact, actually, our number was very similar. 16, 17% was around that number of 10 to 20% with suboptimal quality. But it increased slower than that of suboptimal image quality, and the use was proportionally greater amongst inpatients. And we know that to be the case because inpatients need contrast more. The image quality isn't as great, but also inpatients happen to have pre-existing IVs, and that's one of the major barriers for use. So we did a lot of things within our lab, and to try to better align the incentives, we were able to push through the hospital a program that allowed sonographers to be able to give and administer contrast by themselves without asking for physician approval ahead of time. And that has really dramatically changed our program. So one of these times, Steve Feinstein came up to me and said, hey, you should really edit your slides to update that. So here we are. This is only up to 2022, but it's about the same. And so our rate of ultrasound enhancing agent use has really now matched that of suboptimal image quality. We do about 40% of our studies with contrast, which is compared to nationally is quite high. And lest you think this is just an issue with BIDMC and we're just practicing poor care, this is data from around 11 million adults receiving echo and 740,000 receiving stress echo, about 93% of the US transthoracic use and about 94% of the stress echo use. And on the top left, you can see the use of transthoracics overall. On the top right, the use of stress echoes overall. On the bottom left, you can see the proportion of those echoes in which contrast was used. And in the bottom right, you can see the proportion of which contrast was used for stress. Overall, it was used in about 6.8% of outpatient transthoracics and about 21% of stress echocardiograms. So way more used off-label, in fact, than on-label. And if you just look at places like, I don't know, New York, because it's nearby to New Jersey, you might think, wow, you're doing a lot of echoes, but in fact, actually, New York is not, in fact, doing a lot with contrast. When we sent this in, the reviewer on this happened to be somebody from Houston, and they said that the data can't be right because we're using a lot of contrast at our XYZ institution, shall we remain unnamed. But in fact, actually, across the state, you can see that woefully low in terms of the overall rate of utilization. And this is very variable by state. So this is by state, looking at the same publication. In Minnesota, you walk into an institution and you have about 20% of echoes get contrast, versus Delaware, it's only about 1.1%. New Jersey is somewhere in the middle here. But there's a very big difference. But of course, the patients aren't different, right? So how do you know that the patients are? This isn't just a factor of the patients that you're seeing. And so we did account for that. In general, across multiple studies, we've seen females receive less contrast than males, even accounting for suboptimal image quality. It may have to do with some of the overall sort of gender biases that exist with care more broadly. Older individuals, people with more comorbidities get it more often. Sites that use contrast were more frequently large, rural, nonprofit, and teaching facilities. But even after accounting for all those and a number of other variables, we've still found about a 4.4-fold difference in use by site. And that really speaks to the need, better need for standardization. And so the AAC has tried to get at the reasons for why this is the case, and has published a number of different surveys. Every year they publish a trend survey which asks not just the AAC population but the overall ultrasound population to weigh in about trends facing the field of ultrasound. And in a number of them they have asked the questions about contrast. In this particular one, I believe this was 2021, they asked, please rate the degree to which you find the following tasks difficult, thinking that people were going to say longer studies or just the sheer number of patients, and then those were on the list. But in fact, the most common thing, and this has been true when I've talked to groups of sonographers and around the country, is really it's technically difficult patients due to body habitus. It's a really, really big challenge. As our population increases in weight, it's more and more challenging, in fact, to get those sort of diagnostic quality images. What are the main barriers preventing your lab from using contrast for LVO more often? And the number one thing is that it's too much effort, and the number two thing is that sonographers aren't trained in the administration of use. And number three is that there's a workflow issue. So there's some things to be overcome here. If you then go on and ask them what would be the top driver to increase appropriate utilization, most say the ability for sonographers to insert IVs, and number two is the ability for them to inject contrast. And so not a surprise when you ask where they're being most underutilized, it's the hospital outpatient setting that rises to the top. And that's because those patients come in without an IV. And so what happens, it used to be at our center, certainly is the case at many centers, if you call for an IV nurse, you take your first pictures, you say that the patient needs contrast, you call for an IV nurse, it takes 40 minutes for the IV nurse to get there. That's 40 minutes out of an hour-long exam. Well, if you just start doing the exam 40 minutes into it, you're really not going to have a lot of time to do the exam. And so people just forego the use of contrast as a whole. And this was actually studied formally. This is a survey that Sharon Move and others from ICUS put out to 227 program directors for sonography schools across the US. And what they found was that only 18% offer any IV insertion, only 5% certify sonographers on IVs. This is a real big problem. In our institution, when we look to establish an IV program, we look to existing fields to see how they were able to do it. And MRI and CT technologists all leave training with the ability to be able to place IVs, and that is not routine or consistent, or at least hasn't been to date for sonographers. And so when you ask them why they don't have contrast in the curriculum, the biggest barrier is that the current sonographers and educators don't have sufficient expertise. And what happens is there's a self-fulfilling prophecy where people aren't trained, they can't train the next generation, therefore, and the next generation doesn't learn to train the generation after that. And so we really need to break this cycle, and it starts with sonographers and it starts with underlying training. And I'll get to some of the things we've done in this particular area. 4 overriding practices that we've published on really heavily influence contrast use. So if you're looking to start a contrast lab, number one, standing order for contrast administration. If you have to go back to physicians to say, we need contrast for the study, that's an extra barrier that is enough to be able to interfere with the use of it. So at our lab, we used to have order an echo as with or without contrast. Now we've switched to Epic, and so we can't do that, but what we can do is the sonographers will make a decision, and they will put in an order for the contrast and co-sign it to the reader of the day who signs those out, and that seems to be something that works. And the sonographer is enabled to make the decision and administer contrast. This is within their scope of practice. It's within their, both the SDMS and the American Society of Echocardiography. It's now part of the national education curriculum for sonographers. We got through this at our institution because there were ophthalmologic techs that were giving Timolol eye drops under supervision, and so there's a precedent for being able to do that. I can tell you we've scoured the state laws. Many people say, well, we can't do this in our state, and that's not the case. We have not been able, we've had a legal scholar go through this state by state and have not been able to find any statutory or regulatory guidance that says that sonographers are unable to administer contrast. Sonographers trained and enabled to place IVs, it's a big one. If you have to ask that IV nurse to put in an IV, it's going to take a long time. So what we had is our sonographers went up and trained with our cath lab nurses, and we bought them an arm, and they got practice in putting IVs in, and now they're routinely doing this and really quite adept at it. And it overcomes that barrier of sort of feeling a little uncomfortable about the IV after you have sufficient practice. And then the presence of a physician or sonographer advocate, and really both ideally, because those are critical in pushing this along at a given institution and making the rest of these happen. If you only have a limited amount of time, how do you reduce the decision time? One is reduce the time to decide to give the contrast. So we at our institution start with our apical views. The only reason we start in echocardiography with a parasternal long axis view typically has been M mode. It's a vestige of the older M mode era where in fact we were measuring wall thickness and dimensions based on M mode from a parasternal long. We don't need to do that, and so in fact we can start. We actually know in fact that the apical views are best for assessing the improvement from contrast enhancement, and so we start with a 3D acquisition, triplane, all the cardinal walls. We have strain that we can do, EF, all in one heartbeat, and we can assess for image quality and decide whether or not we need to give contrast up front. We have all of these locally, so we carry the contrast on the actual carts themselves and bring them to the patients themselves. And then we flatten the barriers for sonographers to be able to give that, and that really allows us to be able to use quite a bit. How do you know who needs a potentially contrast ahead of time? So we said, well, this is a kind of a prediction question. We used the same echo data set to derive and validate an algorithm that really used only information that was available prior to image acquisition to create a prediction rule for either the use of contrast or the presence of suboptimal image quality amongst outpatients. So either they got contrast or they maybe could have benefited from contrast, at least were a potential candidate. And with the idea being that if you have somebody that's high enough pre-test probability, you could call them up a week ahead of time. You can have MA calculate the score for everybody a week ahead of time, have them come in 15 minutes early, place the IV, and then it's your judgment looking at the images themselves of whether or not they need contrast, as opposed to whether or not they have an IV or not, which is really a workflow issue. Turns out that weight, age, and heart rate were most important here. More than BMI or BSA, weight would seem to be most important. Age makes a lot of sense. Heart rate we think is a proxy for acuity, but seems to be important in driving this. And we've externally validated this at Mid-America Heart Institute, where they used a lot of contrast during that time setting, and worked pretty similar to the CHADS2 VASC score. They didn't have access to image data on suboptimal image quality alone, so even just predicting contrast use alone, it worked fairly reasonably. But I think there's now quite much more to do. We've now published an app, ICUS Connect app. If you have an Android or iPhone, you can go, and it's free. You can download this app. It's a great resource with a lot of things about protocols, etc., but also allows you to get to this page that you can also get to online. You input the 3 variables and automatically will calculate for you the probability of contrast use, and it says if probability is greater than 15, consider use of an IV to support contrast use. And then, I'm very proud to report that this joint effort with AIR-MS, which is the accrediting body that accredits all, the vast majority of sonographers around this country, we've been working very closely with them to create an IV certification course. So sonographers, if they don't get this as part of their initial schooling, can go to this certification course. They do a didactic online, they do a practicum in person, and they are awarded a certificate that they can bring to their institution for the institution to make the decision about whether or not it's appropriate for them to place IVs. But it allows another route for them to be able to get that training outside of training. And then I'm also really proud that just last week, we, through the concerted efforts in the JRC-MS, created national education, the next update to the national education curriculum for sonographers, and that in fact has mandated training on IVs as well as contrast enhancement. So this will in fact change, but we're creating a lot of didactic materials so that people can apply this in their own sonography schools, but this will change hopefully the abilities of our sonographers to be able to meet the demands of care that are in front of them. Last but not least, I did want to talk about safety. It was a really important aspect here, and is a critical part of what we've been researching in it recently. We know that in general, allergic reactions, otherwise known as anaphylactoid reactions, are rare. They happen about 1 in 15,000 cases. This is from overactivation of the complement system. It's called a CARPA reaction. It's called an anaphylactoid, not an anaphylactic reaction, because you don't have to have had prior exposure to the agent to have it happen. It can be your first or exposure. You could have had it many times, and then all of a sudden your fourth or fifth exposure, you have a CARPA reaction. But because of that, it presents very similar to allergic reactions. It's IEC policy for echo labs to have a policy for early identification and rapid response to these. And then all personnel really need to be trained, and that's anybody working in your lab, on how to respond to this rapid response. Allergy kits in general we recommend to be available and accessible. Turns out that many people reach for their code carts, but even pulling out the epinephrine from a code cart at a dose of a code cart, you're getting a concentration of epinephrine about 1 in 1,000 versus 1 in 10,000 in an EpiPen. 1 in 1,000 can actually cause coronary vasoconstriction. 1 in 10,000 should not. And so there's some relevance to having potentially some of the data, some of the things that we have in here, like an IV start kit, a saline bag, or otherwise, that may not exist in a code cart. Most occur immediately and occur with sort of pretty typical, prototypical symptoms of anaphylaxis. There is a low incidence of temporary back pain. This is felt to be due to potentially complement deposition or activation in the glomerular capillaries. In general, we think that the rate both of CARPA as well as the rate of back pain is related to the peak dose bloodstream concentration. And so slow infusion, slow use of this, slow bolus, as well as diluted agent can help with it. Anecdotally, I've heard some people say that you can use a high MA ultrasound, put it on somebody's back, and have it break up those complement deposits. But in general, it goes away over time, and the back pain itself is not of clinical concern. The biggest thing is what we've noticed is that going around to labs that many people don't have protocols for safety. And maybe much like radiology in its infancy, we in non-invasive cardiology are not used to having events happen. And so therefore, staff may not be prepared when those do happen. And it's really important to train people. Clinical application specialists, ICAS, all great teaching resources. Train your staff through examples, have them repeat back those safety protocols. We assess and reassess people's competency on an annual basis. And then planning for the local response is really critical, the when, the how, and the who. So when we started a clinic in Lexington, we didn't let them use contrast until we knew exactly who was going to administer the contrast, who was going to respond in the case of emergency, and what happened if that person was away on vacation. Having those allergy kits available and stocked is helpful. And then if you do have a reaction, tracking the issues, retaining the vitals, reporting the details, which is relevant to all of the companies have pharmacovigilance groups, but they have to report to the FDA on any reactions. It's helpful for them to know as well, and it's also helpful to document it in the chart. And then I think a big part of this is debriefing afterwards. This can be jarring for a lot of people, particularly sonographers or others who may not have had as much clinical experience with acute code-like events. And so it can be helpful to debrief on what went well, what didn't go well, how people are doing, and then ways to improve. And this is what we have. We carry on every single cart, as well as posted in every single room. We have a sign that says, identify yourself, message it, and we tell our fellows to drop everything and run like this is a STEMI to support our sonographers accordingly. But it's also important to keep a context. And so this is great work from Kevin Way, looking at the comparative safety of different contrast media. And you can see that contrast agents, while ultrasound contrast agents, while they do have a risk of a severe fatal reaction that is very, very low, they're among the safest of all contrast media, and that includes low-osmolar iodinated contrast agents. When we talk to our colleagues in radiology within the IPAS board meetings and otherwise, they say, we have way more events from iodinated contrast and gadolinium contrast than we do from ultrasound contrast. And yet, we wouldn't think twice about sending a person for a CTA or an MRA, but we do somehow limit ourselves when it comes to ultrasound contrast for the same reasons. This is the host of studies. This is all of them prior to 2014 that have been published, looking at the safety of contrast, and the biggest one being the main study, Mike Main, in using DEFINITY, 4.3 million patients in the premier data set, accounting for people's likelihood of receiving contrast. They were actually less likely to die, not more likely, within 24 to 48 hours. Now that is probably not causal, but in fact it suggests that perhaps that there's significant safety. And so as a result of really some of these, in 2007 the FDA had issued a black box warning in response to 190 cases of severe cardiopulmonary reactions happening in close proximity to contrast. Turns out many of them on review were not actually due to contrast itself, and over time there's really been sort of this concerted effort to claw back the safety warnings on contrast. And in fact, actually, there's no longer a requirement for monitoring. There's no longer a contraindication to use with that of shunts or even in pregnancy. The theoretical concern in pregnancy and as well as with shunts is that if you have a large clump of contrast that doesn't declump, deaggregate, it can block a blood vessel. But in fact, your vascular bed is so huge, and these definitely do not aggregate in the same kind of way. And it has been shown in small series to be relatively safe. We try to limit the dose that we give when we give it, but we certainly do use it in pregnant as well as patients with shunts. In pregnant women, the concern is that it could occlude a placental vascular bed, but in reality, it does not happen. So what does happen? And I think this is getting to the more recent history, and this is where this has been really a hot button issue recently, in that contrast, like many other things, has polyethylene glycol. Polyethylene glycol, or PEG, is really sort of in everything we do. It's about 20% of or more products, including consumer products across the market. It's a stabilizer. In this particular case, the PEG is used to be able to improve or decrease the opsonization from an immune system, so it decreases the immune reactions. But yet some people actually have allergies to PEG. And so this was a case report that was released by one of my colleagues, Cosby Stone, who's an allergist at Vanderbilt. He was taking care of a 58-year-old car mechanic who was exposed to multiple types of paint that had multiple different formulations of PEG in it, and had received DEFINITY. And 3 years ago, he had a history of anaphylaxis to steroid injection. 8 months ago, he had anaphylaxis to Miralax, which is essentially just PEG, for colonoscopy prep. And then 1 month ago, prior to presentation, he had an anaphylaxis to DEFINITY with a stress test, and you can see a wheel that occurs with increasing strength. And we know that this PEG relationship is dose dependent. But this became a real important issue because the mRNA vaccines that we used for the entire population and vaccinated the entire population for COVID-19 are essentially lipid nanoparticles that contained PEG at a molecular weight of 2,000. It was at the time, the only recognized allergen in the vaccine. And while we know that PEG allergy itself was exceedingly rare, the reports, at least in the literature, of PEG allergy had been increasing. We know it was the first vaccine to have PEG in the vaccine, and in fact, 24% of the population has evidence of prior immune exposure to PEG. So it's theoretically plausible that, in fact, PEG could be the culprit for many of the reports of anaphylaxis that were going on. That's the reason that this was such a focus of both the FDA and others. Lena Garvey, who's an allergist in Denmark, who was trained in Britain, published this first, and then was subsequently followed up by a number of different reports, both reacting to the COVID-19 vaccine itself, but also linking that potentially to why people were seeing anecdotally increases in rates of adverse reactions to COVID-19. This was a paper from Penn that looked at EHR vaccine adverse events, which occurred in 24% of those with contrast reactions versus 4% of controls. All were non-severe and occurred really right after the vaccine dose. And so theoretical plausibility. And so as a result of this, and as you can see on the right here, this was the same case report from Cosby Stone's group that initiated this FDA MedWatch report. In 2021, the FDA issued a MedWatch report and presumed hypo and hypersensitivity reactions due to PEG. It was based on 11 cases over 10 years. If you do the rate of reaction, that's less than 1 per million doses. None of it was laboratory confirmed, but as a result, it was a cautionary. There were new contraindications put on these agents in those who had known hypersensitivity to PEG or bowel wraps. The thing is that PEG has been in these agents since before the safety data that I showed you was there. And not only that, but PEG also is very similar, structurally similar to polysorbates. And there's cross-reactivity in about 30% of individuals. So there's seemingly sort of things that didn't quite fit. And then this paper came out, and this really changed our field in a major way. It had a very chilling effect, I think, in many ways in the use of contrast. It came out in JACE, but looking at 4 health systems, 81 hospitals. Unfortunately, they only looked at 15% of the hospitals that actually experienced adverse events and not the 85% that didn't. They looked at use of particular agents, so they ended up saying that Lumason was at higher risk than some of the other agents, but they compared contemporary use of Lumason to historical use of Definity prior to the era of COVID. So, moreover, most of these serious adverse effects were uncommon. They weren't really tracked the same way across site, but it was hypothesis generating. And in fact, actually, they identified that perhaps there was an association with the COVID vaccine. And that's sort of an interesting point here. And many of us have experienced, in fact, individuals with this. This is a report that we published in Circ Imaging on an individual who had Kunis syndrome, which is an allergic ACS, acute coronary syndrome, in response to either causing vasoconstriction or thrombosis that can occur in response to mast cell degranulation from allergy. And this happened in an individual who was otherwise had a stent and was sitting there, got a contrast echo, and in fact had ST elevations, chest pain, rash, and we took him to cath and found that he had a spasm right coronary artery in the setting of this allergic reaction. So many of the more severe cases may be due to that. We think that is pretty uncommon overall, probably less than 1 in 20,000 cases based on what's been reported in the literature, but it's still enough that we want to be sure that we are prepared for that. And so one of the things we really realized was that labs weren't prepared. So we created a standard document, and this really was, across 14 different cardiac societies, including the AAC, the British Society of Echo, the Canadian Society of Echo, the Society for Diagnostic Medical Sonography, AIUM, and others, to support the safe practice and essentially outline what constitutes safe practice for a lab in administering. But second, we also said we need better data. And so we looked back and we did a large study that was published in JAHA recently, and it's a wonderful editorial by Matthew Sarfletto, looking at the contemporary safety. Essentially, we reproduced the Mike Main study. We took patients across multiple insurance types, 21 million patients overall, and propensity matched them based on their likelihood of receiving contrast versus not, and then looked at their likelihood of having an adverse event. And here you can see SMDs these are not p-values, they're standardized mean differences. And so anything less than 0.1 indicates sort of no significant imbalance. And we can see that, in fact, actually, the rates are pretty similar in the matched cohort across these different outcomes, including, importantly, death. And then if you look at adjusting for likelihood of receipt, those who received contrast were actually less likely to die within 48 hours compared to those who didn't receive contrast. And that was true across the type of brand that was ultimately received. And this was true across years too, unless you think it was just a COVID effect, etc. We see this across those. So how do we reconcile these? And I think it's led to a sort of a number of challenges. We did bring back that patient with Kuhn syndrome and tried to do 2 years later. We finally got him back in the clinic, and we tried to do a test to see if he had any reaction to PEG, but in fact 2 years later he did not. He had a normal baseline tryptase level, and his skin prick testing and all was negative. And what we don't know of this is in fact, did he have anti-PEG antibodies that waned, or was there some non-immune mediated mechanism that could be at play? Now, what's really interesting, and this is now under review by an article by us under review, is if you look at actually the COVID-19, you see a very similar sort of rise and fall in overall adverse reports to the FDA. Now, this is with the caveat these are only those that are reported, but we see a pretty similar rise and fall, and reassuringly a fall in 2025. And if we look at to the extent to which there was reporting changes that shifted the denominator, we can identify that about a third of the increased risk of contrast observed during COVID was due to reporting. The remaining, however, was due to PEG. And we can say that now sort of pretty reassuredly. If you look at the graph on the right here, serious adverse events, it wasn't different between Lumasan or Definity as a function of their overall use. But Optisan, the one agent that doesn't contain PEG, was in fact very, very, very low rate of events overall. And what's more, however, if you just look at this, you might say, wow, we're switching to Optisan tomorrow. I think it's important to contextualize this, and that might be fine, but it's important to contextualize this in the broader scheme of what we do. In fact, risk of gadolinium and iodinated contrast fell during COVID-19, but despite that, the risks comparing ultrasound contrast to other contrast agents were substantially greater. So even though we did see a small increase in the rate of contrast reactions, it was substantially less than that of other types of contrast media still. We used a positive control. Neulasta has a risk of it has PEG in it. And so that, in fact, PEGylated agent rose annually over the same years as did the rest of the PEGylated agents, versus those agents that didn't have PEG in them, in fact, actually didn't have the same kind of rise and fall. So how do we move forward? In the last couple of minutes, I just wanted to say, so this has now been published just right before the new year, that we developed and tested in a very small group a screening checklist to identify patients with suspected allergies to PEG. This is a pilot study, comparing people with known PEG allergy to those who didn't. We were able to use this as a screening tool to identify 100% sensitivity and specificity for those with known PEG allergies. We need a larger study, and so this is just, at this point in time, a preliminary work. But what you can see is there are in fact lots of things that, while we ask about bowel preps, there are lots of things, and in fact things like depot steroids have PEG in them. There are lots of things that do have PEG in them and in fact can cause PEG allergy or precipitate PEG allergy in people who are otherwise exposed to it. So you have to think about the whole picture, and we've seen many of the cases that have gone wrong have been in people who had PEG allergy, but it wasn't recognized as being due to PEG. The other aspect of this is we are thinking that in fact PEG can potentiate carpal reactions, and so it could have been that even if they don't have an immune or anaphylactic reaction, the typical complement reactions were more common in the setting of people with known IgGs or IgM antibodies to PEG, and so that creates another whole host of challenges to deal with. That being said, I think it's important to contextualize all of this. This is a report from the IOM showing postmortem examination research spanning decades has shown diagnostic errors contribute to approximately 10% of patient deaths, and a third of patients experience misdiagnosis in their lives. It accounts for hundreds of $billions in costs. And so I think it's really important to understand that if we have a technology at our discretion, my perspective at least is as long as it's safe, relatively safe, and the benefits outweigh the harms, why aren't we using it more? And so with that, we'll take any questions from the group.
Thank you very much, Jordi. Very comprehensive. And I think the last portion was very interesting to note the spike and the fall, and some of the work that you're doing is really important for understanding the pathophysiology is really nice. I think Dr. Magandhi has a question, and it's in the chat. Uh, a quick for you. It is felt that PEG is responsible for most of the car park. Given the differences in PEG concentrations with different ultrasound agents, would you choose one over the other?
Good question. So we don't know that PEG is necessarily responsible for most of the Carper reactions. The Carper reactions can happen without PEG, and one of the challenges is that if you take PEG out of the agent, they actually are more likely to have an immune reaction than not. And so it's sort of this catch-22 where PEG overall decreases the immune reaction, but a small subset of individuals are prone to having reactions to the PEG itself. And so that's, while PEG overall may be net favorable to include, there are a number of companies I can tell you that are working on non-PEGylated options. It's really a question of what do they use instead of the PEG. There are ways of modifying the PEG as well, and sort of including branch chains and otherwise to make it less likely to be an immune target. And then the concentration, of course, is an important one as well. There are, so just to put it out there, Lumison has a higher concentration than Definity, which has a higher concentration than Optisyn, which has no PEG. But there's differences in how that PEG is integrated. So the PEG with Definity is actually part of the lipid shell. It's integrated into part of the lipid shell, where it's an excipient as part of Lumison. So I don't know that we can necessarily draw from the molecular weight and the direct involvement that Lumison is higher risk. Anecdotally, people have reported this for Lumison and not as much some of the other agents. But from the reporting data we see, it clearly is happening in Definity as well, and it is clearly happening to the same degree with Definity, whether or not it's being reported as such by anecdotal reports or case reports is unclear. So I mean, if you really want to be safe, Optisyn is a great choice. I'm gonna stand here and say that one is better than the other. I'm not vouching for any particular company or the other. It is at the end of the day, there are advantages and disadvantages. People tend to use Optisyn very differently to the way they use Lumison Definity, and that confounds the picture as well, because they tend to use Optisyn in an outpatient setting and Definity and Lumison in an inpatient setting. And so that makes it very difficult to disentangle some of the effects of this. But I do think that in the future there's more work to be done to create non-PEGylated agents. I think in the meantime, the most important thing is that you have a good safety program in place, so that if a reaction does occur, that you're there and prepared to deal with the response.
So, Jody, I'm going to ask you a question which is pertinent in this age of AI, where the machine settings are, people are not using knobs anymore. The AI automatically adjusts the settings. Have you seen a difference with some of the newer technologies and the use of contrast? Number one. Number two, are people patient enough to be able to change the setting, or they're using contrast more often? Because when it comes to the economics, the use and overuse of contrast, I mean, there's like a fine balance. Like if you use too much, then you lose some of the economies, particularly in the inpatient settings when you don't get paid for it. Versus if you don't use it, you don't see it.
Yeah.
And then you're now compounded with the AI, where people are not going to use any more knobology to really do any tweaking before deciding. Where do you think where you're heading?
Yeah, it's a really interesting point. Interestingly enough, when we looked at the billing data, so when we validated the codes for use of contrast, we had a large sort of claims data set linked to EHR data, and looked to see did they actually get contrast and what did the claims show. And it was very good in the outpatient setting to be able to track the use of contrast because they get paid for it. In the inpatient setting, it was horrible. And that was part of the reason why we made our analysis looking at utilization of contrast about outpatients because, in fact, we had very low sensitivity and specificity in the inpatient setting. And I think part of that is because it's accredited against the institution when you're getting paid with single DRG. So yeah, there's a lot more to be done there. We really don't still even understand even what the utilization of contrast is amongst inpatients and who it's used in. AI would be great. I don't know of any tool yet that automatically adjusts the settings for contrast. I think it depends a little bit on what your goal is in terms of what settings you want and what you're doing, if you're doing TE or transthoracic, etc. But I would say the vast majority of people just use the out of the box software, and the out of the box settings are LVO settings. They often have a high MI. They're good for edge detection. They're very robust, but they're not really good for doing things like looking at contrast perfusion or targeted molecular imaging, or even to allow for that contrast to persist for a longer period of time. So getting those reps in there to be able to tweak the settings so you can get a better setting on your device can be very helpful. Does that help promote people to use it? Yeah, I would say so. I don't have definitive evidence on it to say so, but it's interesting that contrast is the standard there for volumes and EF assessment on echo, and yet at the same time, up until about a year or two ago, there weren't any contrast AI softwares that could do quantification of LV volumes or EF using contrast enhanced images. And that's changed, and we actually have a paper now that we're going to be submitting soon looking at research or timing and workflow and how it can help both from assist with timing and also at least one of those tools is very good at assessing EF and volumes. But it's a real challenge, and EF contrast has been sort of the second sister, so to speak, to regular echo. And even when we were sitting down with the writing group for the guideline, the upcoming chamber quantification guidelines for AAC, one of the questions came up is what are the normal values for contrast volumes? And nobody knows that, because all of the normal values have been taken in people who are already referred for clinical evaluation because of some suspicion of disease. And they're not the same as those who are in the general population who may have an echo done for research purposes or otherwise. So I think there's a lot more that we need. We need to understand also the time varying aspect of that too. When is the right time in the relative to the administration of the contrast to optimize those settings and to take your pictures. And right now it's sort of when it looks best. But I think quantitatively figuring it out for particular devices could be a really great use of AI.
Yes, and I think Dr. Mills has a question. He compliments your presentation. Do you see ultrasound agents being used more in the future to assess macrovascular function? That opens up a really important, MCE, myocardial contrast echocardiography is really underutilized. What do you think, Jody? Why are we not able to use it? That would be very powerful.
Yeah, so I agree that microvascular function would be a holy grail. There's that's being worked on actively. There's a number of groups that are working on this, both from industry and otherwise. And one of the big challenges has been the frame rate of imaging. The heart's a difficult structure to image because both of the respiratory motion, there's translational motion, there's the issues of acoustic shadowing with ultrasound. So it can be very, very challenging. And to get the kind of resolution that you may need to evaluate microvascular function right now is not possible. They do this with liver imaging, though. They do time of arrival imaging, where they essentially subtract the baseline time, and you can color code the timing of the arrival of the microbubbles to see, is this a tumor, is this something else, is it a malignancy? And so the technology exists, but of course it's easier to make the liver stand still and have somebody take a deep breath if you're going to do that study. It's very, very hard for our patients to do that, and so it is being worked on, but TBD.
Although I'll have to say that I've seen some work on ultra-fast ultrasound imaging with
Yes.
micro contrast agent, which actually really beautifully delineates the microcirculation. So I think there's more work to be done. And I think to close, we should also mention that therapeutic ultrasound, contrast ultrasound, is an active area of research, particularly for thrombolysis, particularly for people who are interventional cardiologists. I think there's a strong body of work that use of contrast agents post-MI, post-TEMIs when you have slow flow, no low flow. In fact, it can burst the intramural clots and you can have improve perfusion. There is actually a randomized trial that got halted during the COVID on the use of myocardial perfusion using therapeutic called contrast ultrasound. I think there's so many other areas which are still pretty open for investigation. So
Yeah, if I could just say one thing about that, I 100% agree, and I think it's a very exciting area. There are a couple of things that limit that right now. So we did actually one of the Haluska Award finalists last year, and actually somebody who won I think it was the Wyman Award last year, focused on, in fact, actually use of microbubbles for viral vector delivery for gene therapy, with the idea that you can use less virus and therefore improve the sort of therapeutic effect without increasing harm. There's some issues around attenuation that need to be overcome, etc. But it is a very, very exciting area for future development. And I think, my take on this is we can't get good at this as a profession unless we do the basics first. We have to. Only 6.8% of institutions are using it. In reality, it's binary. It's 0 or 100 in a lot of those cases, and averages out to 6.8. But a lot of places aren't using it at all. And so if we don't get comfortable using contrast as a whole and using contrast infusions, then it's going to be harder for us to be able to do those kinds of things like targeted gene delivery. The other part of this is the infusion part, which is how do we standardize the dose? And that may be challenging at present, but that's going to be coming down the pipeline very shortly. I suspect we will have ways to be able to standardize the dose administered as well as the timing of that and make it easier for the actual workflow administration. So I think this is going to be a larger part of our future, but stay tuned.
thank you very much. So if you got inspired with that presentation, I would just invite all the faculty and the trainees to make sure that you submit your abstracts, because the ASE abstract deadline has been extended till the 21st. Jody, is that right?
Yeah.
Yes. So make sure that you submit your abstracts. We can tell you that we're going to blind it out. We are not going to evaluate, but Jordi and myself, we are going to be making sure that the best abstracts come in. And I'm going to acknowledge everyone for staying late for today's presentation. And particularly also, I see Brian Strom also joined us. Thank you, Brian, for joining. And we look forward to having our continued conversations and look forward to seeing you at ASE and also the other grand rounds. Thank you. With that,
Thank you,
I
Matt.
close. Thank you, everyone.
Thank you for the invitation.
Bye.